Thanks, John, for that really nice introduction. It's really great to be here, and I'm really glad I got to follow the presentation before on global health by Dr. Kohler. In many ways, I think, while I'm an architect and this is going to be about architecture, I want to use a kind of public health and global health paradigm to talk about what I'm calling empowering architecture, or sort of a new direction for architecture. As John mentioned, this is going to be based on a kind of case study of Bottari Hospital, which just opened in January. As you can see, it's in northern Rwanda in this sort of beautiful landscape. And I'll talk about it through this case, but in kind of the lens of public health, and maybe at the end come out with some lessons for how we can address design, and architectural design in particular. I want to start with a story about my friend Cody Berkey, who you can see here on a cell phone. This is pouring the slab for the second level of the hospital. Cody was donated to us from an architecture firm, Hart Howerton. They gave him to us for about 9 months to help run construction and live in the community, live on site here in the northern mountains of Rwanda. And Cody was an amazing guy. He worked really, really closely with the community. And when he came back after a sort of 10-month fellowship, he presented the work of the Bottari Hospital and the vision for an architectural model of healthcare solutions to his firm, Hart Howard, and a large corporate firm, a large planning firm. And he was asked after the presentation, Cody, why build a first-rate hospital when you can actually build 2 second-rate hospitals for the same price? This was from an architect, so I find that kind of interesting that we could even diminish the role of sort of first-rate architecture. But I think a viable question that a lot of people have asked me, why, in many ways, do the best when you can do 2 for the price of 1? Cody's answer to this question, I think, is kind of indicative of the type of work that we aim to do, but also what is possible when you're working in these settings, not unlike Dr. Kohler mentioned. His answer is in 2 parts. And the first was, with appropriate design, or with contextually based design, we can build actually a first-rate hospital for the price and the timeline of a second-rate hospital. That's kind of a profound notion, that design intervention can address those 2 metrics, which we seem to think are the important ones for, say, second-rate hospitals. His second answer, I think, was even more important, and that was really that the poor don't deserve a second-rate hospital. This is also, I think, quite a profound notion, one which our mentor, Dr. Paul Farmer, has talked about in his work with Partners in Health over 35 years of working in global health, and it's called the preferential option for the poor. Really the notion that the poor, the most disenfranchised, the most disadvantaged, deserve not simply the bare minimum, but the best services that we can provide. And in public health, this has certainly been a call to action. In global health, this is sort of, in many ways, what many people go out and do, and I think what global health has grown and blossomed in the last decade. This is a lot of what that's about, and a lot about Paul's teachings. But in design, this isn't really the case, and I think for us, it became an opportunity to think about, actually, what is the role of the architect? How can we provide the best of professional services? When I met Paul 4 years ago, he was talking at the Harvard College on World AIDS Day. It was December 1st. This was, I think, 2006. And he was talking about all of the work that they're doing in 11 countries over the world. They're working in Haiti for 35 years, recently in Rwanda at that point. And he was talking mainly about infrastructure. We're building hospitals. We're building clinics. We're building schools, actually. We're building roads and also homes for people. As a young architect, I found this pretty fascinating. He's actually talking about better delivery of healthcare, and he's using architecture to explain it in many ways, what I would call architecture. So afterwards, I said, well, this is amazing. Of course, I want to get involved. So I went up to him after the talk and asked, Paul, who are the architects that you're hiring for this work, and how can I link in with them? Of course, he said, architects. Why would I use an architect? I drew the last hospital on a napkin. So, the idea that not only can Paul Farmer, who could probably call on anyone who wants to come work on this project, or any number of projects, not use a professional architect, but that they weren't available, actually brought up a kind of bigger holistic issue that I wanted to figure out how to address. In conversations with him, he really talked to me about really 2 main ideas. The first is really linking design to capacity building. The idea, and this goes back to the map that we saw before in the previous presentation, but that there isn't really enough capacity to answer that call of where are the professionals working. And I'll give you an example. This is from a UN Habitat report. 70% of the world's planners and architects are in the quote-unquote developed world. US and Europe mainly. But of course, the majority of the projects are in the developing world. If we look at Africa in particular, there's about 35,000 architects in the whole continent of Africa. Italy is on the right for a little scalar relationship, with about double the number of professionals. And then when we look in particular, in Rwanda, where we ended up working, there was under 10. This is in 2006. And just another side note that the distribution, of course, isn't even throughout Africa. 25,000 of those are actually in Egypt, something about the pyramids maybe, but more probably about the professional capacity, the educational components in Egypt that taught architecture as part and parcel of that educational system. This is kind of a fascinating and I think striking number. And this is, Kinshasa, Nairobi, Johannesburg, Cape Town, large, sort of rapidly growing urban centers have a great lack of capacity of professionals that are able to rethink their systems and innovate within those systems. Thus, when the money's being invested, a lot of professionals are coming from the exterior. This, I think, lends us to think about a bigger holistic problem, which is that without the infrastructure professionals, without the kind of experts, without the training and capacity systems, the support that's needed for these NGOs and small governments to provide the kind of services they aim to provide is greatly diminished. This, of course, is an image from Haiti, where we just started working, where one could say that the earthquake wasn't responsible for the deaths of 200,000+ people, but the failure of buildings. The second concept I think that Paul really sort of talked about with us is actually not only the lack of capacity in healthcare, but also in architecture, but the potential of design to actually provide solutions, or rather in response to a failure of design to actually produce success. One case in particular is the case of what's called extremely drug-resistant tuberculosis. TB, as many of you know, is an airborne disease. It's transmitted through the airborne route, meaning one coughs and one can contract it. Drug-resistant strains are born by one person with one strain of TB transmitting to someone else with another strain. You co-infect, and suddenly you have a sort of drug-resistant strain. So multi-drug-resistant tuberculosis emerged in many countries all over the world 20 years ago, and in 2005, a version of that, an extreme version of that, extremely drug-resistant tuberculosis, emerged in Tagulaferi, South Africa. This strain is resistant to 5 of the mainline drugs that treat TB. MDR-TB is resistant to 3. So this is really the potential of a global pandemic, an incredibly virulent strain of the drug, of the disease, and all of the patients that encountered it died within 3 months. The reason for this transmission is because they all met, it has been shown that they all met in primarily the same clinic, meaning that the patients received this disease, cultivated it, and contracted it in this clinic. This is meaning that the design of the clinic, most likely, helped to incubate. The failure of design helped to cultivate and produce transmission of this disease. On the right is an example of a sort of typical ward that we saw many of in Rwanda. USAID funding was building over 100 of them when I moved to Rwanda, what we would call a poorly designed typical ward. It's a very simple, bare minimum, what you might call a second-rate clinic. It's got a double-loaded corridor, we say in architecture, which just simply means a hallway in the middle and rooms off to the side. And of course, in this scenario, patients found themselves to be waiting in the cool, dark area, in the hallway, which was the least ventilated part of the hospital, of the clinic. This is where they contracted the disease. This is the kind of space which wasn't designed to think about airborne diseases or the types of contextual diseases that we might find in sort of resource-poor rural settings of limited resource settings. Yeah. So here is an example of where design or where architecture has failed in many ways to produce the kind of results it could produce. And the results could be incredibly detrimental. So with that as a kind of foundation of understanding where we can start to address issues as architects, Paul then invited me and then built a team to help design their new project in northern Rwanda, one that became a kind of capstone for their work in the country, scaling what was a rural healthcare model onto a national level with the government of Rwanda. So the Bottari Hospital tries to address some of those issues through architectural interventions. I'll just go through some of those now. As I mentioned, it's kind of in the north of the country on the border of Uganda. It's incredibly beautiful. Even though it's beautiful and stunning and wonderful to visit there, there was 0 doctors in 2007 and a state of 400,000 people. So as you can imagine, all of these people were going to other states in when we might see opportunities for lakeside resorts, this is actually really, in this condition, a very difficult to traverse landscape. So high mountain passes, lakes, so very difficult to get the medical care that's needed. As I said, we just completed it, and the sort of fundamentals of trying to address the issues not only of airborne disease, but also of capacity were kind of driving factors. So I'm just going to flip through some images of it. But the first thing we did to address tuberculosis transmission and try to reduce that transmission rate was we said, well, if contraction is happening in the hallways, let's just remove all the hallways. So this is a hospital without hallways. And that's not a kind of, it doesn't take a rocket scientist to figure that out, but it does take some careful planning, meaning that we use a campus model instead of, say, a large unified block model, something that we might find in, say, the developed world is often being implemented in, say, the developing world. In this case, we had to think about what's appropriate contextually. So to remove all hallways meant that we had to think about an environmental approach and how patients would circulate around the hospital, how we could optimize air mixing in the exterior environment. But in the condition where patients had to wait in the interior environment, i.e. the wards, we had to think about what would happen there if there's a sick patient. What if one patient would come in with TB and then cough, and all these 32 other patients in this ward would then contract the disease? How could we take the most high-risk spaces and try to minimize the rate of transmission? So in this scenario, we worked with Harvard School of Public Health engineers who are experts on infection control. And they helped us think about how to optimize this ward so that we can use all natural ventilation. So again, reducing not only transmission rates, but reducing the need for complicated systems of HVAC. We were able to optimize that and get what's the magic numbers, about 12 air changes per hour, which we're sort of have tested and shown that it works by using simple stack ventilation techniques and just a sort of natural airflow and a couple other redundant systems, just to make sure that it's working even in times of low wind. We have the case of the outside circulation, as well as we have some low-velocity fans that are pulling up air into the upper room and then being cleaned by what are UVGI lights, these sort of lights that help cleanse TB particulates out of the air. So in that, we have 4 redundant systems really working in tandem in an effort to say, what's our worst-case scenario, what kinds of rules of thumb of design can we use, and how do we use the building itself as a preventative mechanism, preventative part of the healthcare delivery program. These are, again, just some pictures of it. I think very essential to being here at the Mayo Clinic is the idea of patient-centric design. We use this strategy as well, and I'll just tell this one story about it, which is, if I'm a patient and I'm in a ward, and what's typical of ward design, as you know, is very doctor-centric, which is what we might call a perimeter-loaded ward, so beds along the perimeter of the ward. We said, well, the last thing I'd want to do, sort of laying in a bed, is look at a room full of other sick patients. So why not invert this idea with a conduit wall down the center, and then every patient gets their view of their own window. This sort of simple adjustment allowed us to actually innovate also in the sort of construction of the ward, meaning we could increase the fenestration size, increase the size of the windows, allowing for more light, more air. But it also allowed us to create this sort of centrally loaded conduit, which we could put in flexible systems. If we eventually get oxygen, if we increase our electrical capacity, we can change out this panelized system. So it became an opportunity, again, thinking about the preferential option for the poor and thinking about patient centricity, became an opportunity to sort of innovate and design and actually sort of produce a better example for the same amount of money. We had other people like Massimo Vignelli, the great graphic designer, donate the signs to us, the sign design, so exciting stuff like that. And then to address the issue of capacity, the other thing that we really realized is that any kind of construction project has the great opportunity to be an engine for economic growth. So in this example, working closely with Partners in Health, who Paul Farmer had started and is the group up there we're working with, we decided to use all local labor. So 100% of the jobs that were produced and the workers were from the local community. This produced over 3,500 jobs. This is kind of also a profound notion because it uses the construction process, really the building process, to engage socially and to think about job creation as part and parcel of the design enterprise. By the numbers, this became quite extraordinary for us. We realized that this is an opportunity to really rethink architecture in general. Not only did it now serve 400,000 people in the district, provide almost 4,000 jobs, use all local labor, and provide a new capacity of medical infrastructure, we built it for a third of the cost and in 2/3 the time of a typical hospital. So in the country, bid it out last year for the same scale and size. So we found that design intervention actually could produce a first-rate hospital for the timeline and the price of a second-rate hospital, something really exciting and something that helped us kind of rethink the way that we approach architecture, not only in Rwanda, but here at home. What Paul would also call in public health this kind of intervention this is a sort of medical term of distal and proximal interventions that I think we can use in public health or even in medicine. It's not often used in design, but I want to introduce it just to kind of think about what is our responsibility and try to seek an answer to Cody's question. Distal interventions are those performed late in the process when patients are sort of already sick. So distal interventions really stop the bleeding. Proximal interventions try to prevent it. Maybe think about the socio and economic conditions that might cause the injury, for example. But the debate about whether to use proximal or distal interventions is sort of as old as medicine itself, Farmer says, and that the sort of solutions are not competing but actually complementary. So thinking about using both the distal as well as the proximal, the systemic as well as the immediate, is the solution to addressing these sort of global problems and the delivery of care for especially the reduction of poverty. I think we can use this also to think about the role of design in addressing these larger systemic problems. What we might call the exigent to the systemic is really how does one architectural intervention affect a system of design capacity. This is a case on the left is Sierra Bainbridge. She runs our team in Rwanda and is an amazing architect and landscape architect. And as soon as she got to Rwanda, she helped work with the Kigali Institute of Science and Technology, where they started their first school of architecture, which she's now the head of the department. So that number of 7 architects next year is going to now be 37. So they're going to be graduating the first class of the first 30 architects in the country. And Sierra and 5 of our 7 people in Rwanda work at the Kigali Institute of Science and Technology, really trying to build that capacity. So building in our own obsolescence in many ways, as making ourselves irrelevant over time, but also sort of understanding a system and learning from a new system of design that's potential and viable in Rwanda, and then trying to map that elsewhere. The failure, one other notion we get from Paul and from the teachings of some of his philosophical foundations, saying liberation theology, this is Johann Galtung, is the idea that if we don't think about that system, if we don't think about the systemic or the sort of proximal interventions, we threaten to actually produce what he would call structural violence. It's actually not addressing the kind of structural systems which would keep individuals from realizing their maximum potential. This is kind of a grave thing to sort of place on designers, that if you don't think about the system in place, you're actually engaging in structural violence. But I would actually go that far. I would actually say that our role as architects in this massive infrastructure development that's going to be occurring in Africa, it's our responsibility to think about the sort of structural conditions which are going to cause that success or cause that failure. I'll just talk about one story that I think talks about that really, really carefully, and that's what we learned while working on this hospital. This is the volcanic rock stone that we used on the hospital. As you can see, it's really amazing way it's put together, this kind of jigsaw puzzle joinery, and we designed it to use basically no mortar. It has mortar behind it, but you can't really see the mortar. These were basically untrained masons. We worked closely with them to sort of develop this system. It doesn't really exist in Rwanda. Keep in mind, it's totally an aesthetic decision to talk about really just the beauty of this stone, which is from that local region. And you can see it sort of used a massive amount of it. But when those masons got started on that corner, you can see what we call the ship's hull, they started building this stone work. And by the time they had wrapped around the whole building, they were so good at putting this stone together, at hand chipping it on site, at fitting it in a perfect way so that it was a sort of seamless connection, that they asked if they could tear down the original wall and rebuild it with their new train, their new craft, which of course we said yes, but hurry up. And they went about it, and now we have this really, I think, symbolic and absolutely stunning entrance to this important first piece of physical infrastructure in this rural community. For us, that really taught me something, and it really taught me that the role of the architect is about first-rate architecture, and aesthetic decisions can be as much a part of structural improvements, as much a part of capacity building, as much a part of training and craft development as can simple, education or sort of a school of architecture. That aesthetic decisions are part and parcel of that. We don't have to sort of surrender our, design training. We just have to build it into a system that talks about the process of that work. If we think about architecture as simply objects, beautiful objects, or terribly ugly objects, whatever your opinion of it is, then we fail really to talk about the process which creates those objects. In fact, I think we fail to actually talk about architecture correctly. We fail to talk about it as what it really is a system. It's a system, and if it's not input over time, it doesn't live long. We have building death syndrome, or buildings that die if they're not used well. This is a way to think about the long-term engagement, not only with the building of it, the social impact, but also of its long-term impact. I think this helps me rethink what Cody didn't say in his response to the architect who sort of tried to engage him on this idea about second-rate versus first-rate architecture, which is this actually is the wrong question. The idea of function or form, the idea or the sort of binary between beauty or function, I actually think is the wrong question. It doesn't discuss what we might call it a false dichotomy. It doesn't actually discuss the structural reasons that produce beauty. William Morris, the great arts and crafts founder, would talk about beauty as that which is created by labor. So it's labor which produces beauty. It's the construction of craft which produces beauty. So it's tying the process of construction, tying the process and the thinking and the design services to the actual output, the sort of functional object, is the way that we have to actually start analyzing success or failure. That's how we analyze structural improvements or structural violence. And these are sort of, I think, our call to action for architects who are interested in a kind of social mission of design, which I don't think there is a non-social architecture. It's as if to say that there's an apolitical architecture. There really is no apolitical architecture. It always involves politics. We just have to acknowledge it, start to address it, start to assess its success or its failure so that we can improve it. So this leaves me kind of with 4 lessons that I'd like to leave you guys with, which is I think there's a real opportunity to rethink design, but especially in the built environment. And outside of just the strategic thinking, actually in the built environment. Architecture can play a role in the prevention of illness. It can play a role in addressing issues of poverty. It has to be tied, however, to the systems approach. So the first is the preferential option for the poor is actually an approach for innovation in design. We weren't hired as architects. We went in and said we can work as architects, and we did something slightly different than just what we might call traditional architecture. And in that, we found opportunities to reduce cost, opportunities to improve the medical delivery system, opportunities to rethink natural ventilation versus HVAC systems in the hospital that we then can map back in this country and elsewhere throughout Africa. Second, building architecture, I think, must be tied to building capacity. Third, the distal and proximal, or the exigent and systemic conditions. These are interventions that are complementary and not competing. And so any sort of architectural approach or any design approach must be thought about in both of these complementary variables. And we have to kind of think about how does each of these projects address both of them. And finally, I think structural violence is potentially, while dramatic, I think also is a good way to think about architecture's responsibility. System failure is part of what we participate in, and apolitical designs engage in that structural violence. So we have to sort of acknowledge the potential in order to innovate, acknowledge the systemic issues in order to really find new solutions. And I think this goes hand in hand with the future of building. Thanks very much. Thanks for letting me be here. It was really great to talk.
That's great.